Okay, welcome everyone. Thank you so much for joining us. I'm Dr. Marina Kurian. I'm the president of the ASMBS, and it's my pleasure to moderate this session today for World Obesity Day. And our guests and panelists today, first is Dr. or Professor Louise Bauer. She is the Chair and Child of Adolescent Health, University of Sydney. And most importantly for today, she is the president of the World Obesity Federation. Then we have our own Gerhard Prager that we all know, who is president of IFSO. And then we have Dr. Jeffrey Metz joining us, who is professor of medicine at the University of Melbourne and is also the president of the World Gastroenterology Organization. And we're excited to join today to talk about some of the initiatives that are there. Welcome, everyone.
Thank you very much.
So there's so much to talk about, and I actually one of the initiatives is really addressing obesity in adolescents. So if it's okay, I'd like to start with Dr. Bauer, and first to hear your thoughts on what the initiative is in adolescents, and then I'm going to have some pointed questions about what some of the specifics can be for treating or preventing obesity in youth and adolescents. Dr. Bauer?
Thank you so much, Marina. And just for everyone to know, I actually work in the treatment of children and young people with in a multidisciplinary clinic in those children and young people with moderate to severe obesity. Well, I think there are several issues to do with treatment of adolescents with obesity. First, and most importantly, we need to actually really address the issue of stigma, because I think that's a major issue for young people. It's why they don't seek treatment. It's why they think they have to deal with it themselves. And we can make a big difference if we, the clinicians with whom we work, our hospitals, our clinics, can actually really have a decreased approach to stigma and can provide an empathetic and supportive environment. Secondly, I think we need to listen to the voices of young people, because there's a lot of things we could do that do better. So if you had that opportunity, involve young people in helping plan for your services. Importantly, all young people with obesity need access, I believe, to good multidisciplinary team services, particularly with those with moderate to severe obesity. They need to be able to access dietitians, psychologists, a whole range of medical people as needed to support them, exercise physiologists, and so on. And in those with moderate to severe obesity, they need much more intensive support. There is a real role growing for pharmacotherapy, and we're starting to see the evidence for that, but it's still expensive and often not accessible in many countries. And of course, for a subset of young people, they need access to bariatric surgery given by teams that are used to working with young people. All of that's easy to say. It's a very different thing to try to deliver to young people.
Absolutely. You brought up a lot of great points, and I appreciate that you're actually taking care of adolescents. And I'm sure all of us have some experience in taking care of. Well, for me, it's not youth as much as it is actually teens that we're taking care of for and offering surgery and or medication. Accessibility is one thing. You brought up that you're trying to take away the stigma. The ASMBS did a study with people, lay people, and it's one of those RAND surveys, and asked if they thought they had obesity or if obesity was a problem. And I think in this country, certainly in the US, that there's some difficulty in understanding at which point their weight is making a significant health condition.
And I think quite honestly, I don't think the size of the person is necessarily the issue, unless they're very concerned about that. It's about their health and well-being, which is related to their size. The Lancet Commission is coming out with a paper in the next few months. I'm involved with that, which is actually just recognising that having a high BMI alone is not the issue. It's around having a high BMI associated with a range of health problems. And we can think about diabetes, heart disease risk, problems with musculoskeletal issues, and there's a lot of those issues in young people, but also activities of daily living and mental health problems and so on. So I mean, you all know that's the important issue. In terms of, and it's one of the reasons why having some form of multidisciplinary team approach to the care of young people with obesity is important. They're much more likely to have problems with depression and anxiety if those goes untreated, or if they think that management of their weight alone with bariatric surgery will cure everything else, then that's not correct. We know that it's really important to involve mental health professionals if there's a mental health problem, just as it is to manage their obstructive sleep apnea, their type 2 diabetes, etc., appropriately. So that's the importance of a multidisciplinary team approach. We know from the Teen Labs study and other studies of surgery outcomes that young people, adolescents with obesity, are more likely to have reoperations or more likely not to have their to run into some nutritional supplementation problems, and also just as likely as adults to have significant mental health problems such as self-harm and suicide and so on. So those issues, it just highlights why we need this approach. Now, not treating young people with obesity is far worse an issue, but when we do treat, we need to provide them with a scaffolding, a wraparound care for all the other issues. It is more difficult. Adolescence is a really important period of time, and if we ignore all those other issues that adolescents need, then they're going to have poorer outcomes for their bariatric surgery or their obesity treatment.
I'll just jump in there, please, Marina.
Of course. Sure.
With Louise and I, we're in conversation some probably 10 or 15 years ago on just this topic, and she embarked on a number of studies on the pediatric sphere, and I moved on to adult world where I remain. In fact, I'm getting into the later adult world as we speak. But in fact, what we talked about at that time was, what can we do about prevention? And I just wonder whether Louise can help us all, help me, as to whether any progress has been made. We talked at that time about exercise for children in schools. We talked about schools having playgrounds. We talked about governments being asked to make more parkland available. We talked about mothers being educated about their children being unhealthy and they needed to feed them healthy food. And we also talked about, in fact, we went to the government in Australia and we said, we want you to legislate against unhealthy food. Please tax the sugary, fatty, salty foods. Please allow the fruits and the healthier foods to have less tax. Are we making any progress on any of those points, Louise? Because that's what the world needs. It's prevention first, isn't it? As well as the other issues.
The healthier the environment in which we all live, the easier it is for people with both severe obesity to live a more healthful life. That will support the treatment, but also we hope to prevent obesity, but it is very challenging. I think we can learn a lot from people in South America, because there's been, or Latin America more broadly, because there's been great, we look to Mexico, which has had its sugar, its soft soda taxes there for a long time, and has seen a decrease in the intake of soda drinks. As a result, we see in Chile with a really integrated approach to promote more healthful intakes and to decrease junk food intake. We've seen some changes there that we can learn. So a lot of the Latin American countries have been real leaders. About 100 different countries in the world have some form of sugary drink tax, although I might add, Jeff, not Australia, which is a sugarcane exporting country. So there are big challenges. So there is the issue about the broader world. How can we make healthful foods cheaper and decrease the exposure to junk foods, particularly for children and young people? It's very challenging. There's this really commercial drive to ill health around the world, and children and young people are really vulnerable to it. But we shouldn't just think about food. We should think about the urban environments, walkability, being able to have environments in which people can move around, not be run over by cars and so on. And we talk about the mothers who drive their children to school because they're worried about their children being run over by the mothers driving their children to school. You can get the meaning. It's very challenging, and we can look to some countries, but we need many other countries to have really strong community and government support for this. This is where the voice of young people could make a difference.
Mhm.
Absolutely can. Gerhard, I want to ask you for maybe a European perspective on this and what, if any, preventive measures have really been successful, because I would say that I'm not, I am familiar with some interventions, even in the 3 and the 5-year-old age in particularly in New York City, but these have not been nationalized, if you will. So any thoughts you have on this topic?
First, I think one has to mention that the latest numbers published 3 days ago in the Lancet show a doubling in adults in the last 3 decades in obesity rate, which means we face now 1 billion of people living with obesity worldwide. But what is more important, for the adolescents, we saw a quadrupling of the numbers. So what we heard just now is so important to increase these efforts to see results. Until now, we don't see these results on a worldwide basis. We see in some countries improvements, but worldwide, we still have a lot to do. And therefore, days like today, the World Obesity Day, raising the awareness is so important. Concerning interventions in adolescents, I think now with the new obesity medication, we have a fantastic, another armamentarium in our treatment, another treatment options. And this has to interfere with all the other treatment options. And of course, at the very end, for those people suffering from a severe degree of obesity, metabolic surgery is one option. I give an example. I've seen today a young chap, 16 years with a BMI of 51. It is, in my mind, very clear that you should not treat him for another 2-3 years conservatively. He has such a long history already. And this is, I think, a message that we have to bring to our colleagues, to the pediatrician, that there is a very effective treatment option in very selected patients by a multidisciplinary team. Surgery is just a part of a big journey these people are going, because obesity is a chronic disease. This is my opinion on that topic.
Mhm. Mhm.
Thank you so much for that. We do have some questions in the chat that I think we can all sort of answer right now when we talk about, one question is the difference between metabolically unhealthy and metabolically healthy. Louise, Dr. Bauer, you made a point about it's about the burden of the disease and not the weight. Any thoughts on that?
If I would just comment, the Lancet Commission has on diagnostic criteria for clinical obesity will be submitting publishing its report in the next few months. It's been in the process that's been longer than an elephant's gestation, but it will be a wonderful outcome from it. But it specifically looks at these issues. It's not just BMI or waist circumference, but it's around the health issues that you have with that, including problems with activities of daily living. I think that's very important. Like if you have big people who live where their family members all live to their 90s and they're healthy and well, why is anybody worried? But if you're looking at, when I see young people who have family members with type 2 diabetes and nobody lives a very long life, you're going to say, well, this is someone we need to intervene much earlier and to support them. Gerhard, you mentioned your adolescent with a BMI of 51. Sad, I see young people like that and actually much higher BMIs. And those are young people for which we go into intensive support mode, which includes now pharmacotherapy. But I just, with the GLP-1 receptor agonist, semaglutide, but in my country, it's difficult to access. And of course, it's very expensive. My hospital is supporting that, but it's still very difficult to access. But we need that. That needs to be particularly treatment for young people. And I think they also need to have a pathway to bariatric surgery, again, in the public system if possible.
I fully agree, Louise. I think we need national plans for that we have reimbursement for these new treatment options, and also centralize the bariatric metabolic surgery for this special subgroup, because those young people, of course, deserve special attention and care by the healthcare professionals.
I completely agree.
So you mentioned the GLP-1s, and I think, that is a place to start, but that's also a place to prevent severe obesity. If we're starting with patients that are have obesity, we should be able to start it then before they reach, BMI 51. I think it's harder to treat at that point with medication. And so, Gerhardt's point's well taken. This is someone that surgery would most benefit. And, our surgeries can get patients down into their BMI of 30s and sometimes below 30. But, we can also consider combination therapy in patients like that to help them even more. Dr. Metz, as the WGO president, there's a lot of research out there that you are very familiar with looking at these medications, but specifically to the treatment of MASH and MAFLD. What my question to you, we are actually in an epidemic and have been for a while of MASH and MAFLD. And there are, therapies to do that. We know what metabolic and bariatric surgery does in these situations in terms of reversing fibrosis in many cases, not all. But the question I have is, while we have surgical and perhaps some endoscopic therapies as well, there are some of the GLP-1s that are reducing biomarkers for MASH. So I want to shift gears a little bit and Louise, absolutely. While we were started off talking about adolescence, not because of your background, but also because it's one of the initiatives. But this is also an epidemic and a sign of what people say metabolically healthy weight. But actually, if we fiber scan everybody, right, we would find that they in fact do have perhaps MAFLD. So your thoughts on our epidemic of MAFLD and MASH, and then what the medications and the procedures and surgeries can do for that. Dr. Metz.
Yeah, thank you. Well, as you pointed out, we do have an epidemic. And as we grew through the last 40 years, we all knew that there was a thing called fatty liver. And the fatty liver disease, we initially believed in most cases was quite benign. And it really took a long time for people to realize that, in fact, there is a subset where these people have the active inflammation involving their liver. And so NAFLD turned into NASH probably about 1980. That was first recognized that NASH was a separate entity where people getting increased inflammation, heading towards fibrosis, heading towards cirrhosis. And increasingly recognizing in the last probably 15 years that there is a further association, which of course is with metabolic syndrome. So people who have the increased BMI, hypertension, elevated triglycerides, low HDLs, and these people have a markedly increased incidence of disease of the liver. I was at a meeting in Vancouver just before Christmas, the American College of Gastroenterology, where they were pointing out that not only is NASH, which is now called MASH, metabolic associated sclerotic liver disease, not only is it being recognized as a very increased risk to us all, but that the incidence of cirrhosis is going to be the greatest chronic liver disease in the future. So forget hepatitis B and hepatitis C, forget other conditions that we look for in people with chronic liver disease. It's the fatty liver disease moving into the NASH, then MASH, which is the dominant liver disease that we're seeing. And I guess that the second part of your question really was, well, what do these GLP-1 receptor agonists and the other products that have been recently described, I haven't used it, but pegozafermin has been described last year, and even another one, resmetirom. Again, we don't have it available. They're experimental drugs at this time, but they've been shown in the last just several months, 12-month studies, to not only control fatty liver, but actually to decrease fibrosis in the liver, and as well as decreasing the activity of their fatty liver disease. And so these are very exciting prospects to prevent chronic liver disease turning into cirrhotic liver disease. And I guess what we're saying is that the associations of just having obesity, then going to chronic liver disease, and then associated with metabolic disease, the risks to these patients are enormous. I like to say, in fact, this is not a controlled study, but I see a lot of patients these days where they believe that having fatty liver disease, they all know they've got fatty liver disease because the GP told them that. But if you show them the data, as Gerhard said, the increased number of patients across the world, 1.4 billion, probably totally around the world, adults now recognized with the disease, and then saying to them, if you don't do something about it, take advice on diet, take advice on exercise, the multidisciplinary team that will help you. In some cases, bring the weight down to some degree with balloons in the stomach to get you to a level where you might be able to go on to surgery. All these various ways of approaching the severe obesity, that there's a lot of patients recognize they reach a tipping point. So, we all know that there's some who can't reach that tipping point themselves, but the tipping point is recognize, I've got to do something about it. I've got to do something now. And they're the ones that I like to think that we can help, not just supporting them, but actually getting them to recognize that if they can get onto the Mediterranean diet and increase their activity with support from all the staff that we've talked about, and these new drugs, that there is a future that they can look forward to.
Thank you for that. We do have, again, some questions from the chat that I would like to get to. One of the things we talked about GLP-1s. I want to get to one of the questions was about the length of duration of treatment with medication, right? But it depends on why you're taking a GLP-1 and how long, and what is the benefit that you're seeking. What is your obesity related health burden, and then how are you going to decrease that? I want to get to that, but Gerhard, I want to hear your thoughts on MASH and MAFLD, because for us as surgeons, we know that our surgeries do improve that and can cause regression. Not in everyone. Garrett and I were at a meeting recently where this was discussed. Yeah. Dr. Prager.
I think Geoffrey pointed it out perfectly. Approximately 1/3 of the world suffers from MAFLD. 1/3 out of this 1/3 progresses to MASH. And MASH has an impact on your life expectancy already. And another, around 20%, can progress to cirrhosis. And when you look at the liver transplant programs of the world, you will recognize that the most common indication for liver transplantation nowadays is MASH. And this is something that is a really big bang. What can surgery offer? Or I would say it's not surgery. It is permanent weight loss, long-lasting weight loss. If you lose more than 20% of your body weight, you will see a dramatic improvement, not only for the MAFLD, but also for your MASH. And we have good data for instance, from the Cleveland Clinic, from Ali Aminian and others, where we can show up to 60% remission of MASH, saying that you must be careful. Around 20% of the patient progress although they have lost that amount of weight. So again, you need a multidisciplinary team. You have to monitor these patients, but metabolic surgery, in this case, I would really call it metabolic surgery, because maybe MASH is the indication for the surgery, has a high potential to improve MASH or lead it into remission.
Mm-hmm.
Dr. Bauer, your thoughts? Because, you know, one of the other things that we know about adolescents, for example, is that when they have type 2 diabetes, and actually there's been some discussion as well about MASH or MAFLD in this group of adolescents, that when they have that in their adolescence, they're more likely to retain that disease burden as they progress to adulthood.
I agree. Certainly by adolescence, if you have health complications associated with your high BMI, then you're more likely to take those into young adulthood and beyond. Those young people are the one, and that includes MASH, very much the case, and certainly pre-diabetes as examples. We are increasingly, you know, in my own clinical service in Sydney, we're seeing young people who have significant problems with MASH and MASLD, who are developing, you know, who are candidates for bariatric surgery, and who we know we're almost certain will go down the track of liver transplantation if that does not need to be the case. So these are all young people with very high BMIs, but with established fatty liver disease and complications. So we take it very seriously there. It's another reason why we need to intervene early in life if people have established obesity. It's one thing to prevent obesity. It's trying to stop people developing obesity in the first place. Once they've got obesity, if they have health problems associated with it, they need treatment. And then all of the issues that we've talked about, really important. And just because they happen to be an adolescent doesn't mean they shouldn't be offered this, you know, really high quality treatment, particularly if they have significant complications or very high BMI. The problem that we see in many countries is that, first of all, it's been slow to get effective treatment available for many adults with obesity, and it's been slower still for that to occur in adolescents, and yet the evidence is very strong for the need for that. So we need to sort of open up our clinics, our services to these young people, and that involves an integrated approach, because they are a little bit more challenging to deal with than maybe many adults, but maybe not. Maybe we're used to dealing with adults, but we can't afford to ignore them.
Well, you know, it's you brought up excellent points, all of you, but it is really my pleasure to have, you know, our presidents that are global, really. And so one of the questions was talking about how to implement programs in countries that may not have as many resources. So from your world perspectives, and I'll start with Dr. Metz, what is the WGO, the WOF, IFSO, what are you doing to help get the message out? And there's so many messages we have to get out, right? But the message is out, like, let's say we're just talking about MASH and MAFLD, but that severe disease that is not visible, right? These are non-visible, type 2 diabetes, MASH, MAFLD. These are things that you can't see on the outside, but they are severe disease. Do you have any initiatives, any thoughts around how we can address this as a public health service?
Absolutely, and thanks for coming back to this question, because it's interesting. On the chat there, I just noticed a couple of questions about people asking about preventive measures, and I think one of the things that we do at the World Gastroenterology Organization, when we look at the guidelines for health in gastrointestinal disease, we have guidelines with cascades. And what guidelines with cascades means is that you map out what is the most effective treatment for any condition. It doesn't matter which the condition is, but you map out what is the best treatment, but then you cascade down to less expensive treatments that you can apply in lower income countries around the world. And there's no question that, as Louise said, there are these new drugs that are on the market now. We use them, although the GLP-1 drugs that we found fantastically beneficial in Australia, suddenly we're running out of them because everyone wants them. And A, they're expensive, but B, they're in short supply. In middle income and lower income countries around the world, you have to think about what is available, and they don't have those access to these drugs. And so coming back to what Louise said before, if you have preventive programs, that's the good place to start. We as a world organization recognize that, and so we are pushing the idea of educating mothers about the dangers of obesity for their children. I mean, I grew up in a situation remembering how many of the mothers around Australia, around Melbourne, where I come from, thought that the best thing they could do was make their children fat. That means that you're a good mother. But in fact, what they really need is the education to say, this is the sort of food you should be giving. There is the program in England of bringing healthy foods to children in school, the school canteens. Louise, have you been following those studies? Because certainly, Jamie, the celebrity chef, whose idea it was, it's really about saying to the children, we're not beating you around the head with a stick. We're saying, here's the best thing you can do. Have this food. Louise, have you followed that?
Yes. Well, actually, my own research, I'm very involved in a sort of a global group looking at early prevention of obesity in childhood. What we know in many, particularly high-income countries, including Australia, that many children a large number of children are already affected by overweight and obesity at the time that they start school. So in Australia, that's about 1 in 5 have overweight or obesity at the time they start school, and 1 in 4 by the time they finish school. So if we leave it just to school time, it's too late. And what we need is interventions across the life course. So that's supporting mothers to have healthy pregnancies, looking at interpregnancy weight gain for mums, but also in early childhood promoting healthy infant feeding and beyond. And there's a lot of strategies, including my university's done a lot of work with this, but a global groups looking at these. This is part of the sort of background, how to support healthy environments for children. And it's also around having healthy environments in schools. But it's hard for children to, children can't be the only ones making decisions. They're really important, but they need parents, they need the broader community, they need support from government, so they're not exposed to unhealthy foods. Remember, the healthy foods are usually the expensive foods. The unhealthy foods are the cheap foods that are heavily marketed to children and young people and are full of sugar, salt and fat that people like to eat. So we can't just, I think it's really important to do that, but we need to even take a further step back and say, yes, we need healthful environments, but we need something more that's going on. Maybe I could just briefly explain about what World Obesity Federation is doing more globally. We're working with the WHO on its Obesity Action Acceleration Plan, where they've got, I'm just trying to remember, 20-odd front-runner countries. So that includes several in different parts of the world, including Argentina, Bahrain, Brazil, Chile, Mauritius, Mexico, Panama, Philippines, Portugal, Slovenia, South Africa, Thailand, and so on, to work with those front-runner countries to support them in tackling obesity. And that's not just, it's partly on treatment, but also on provision of effective prevention strategies and trying to really support people nationally, leaders nationally there and governments, to be able to implement strategies that will make a difference. So this is seen as, this is a World Health Assembly resolution in 2022, and this is seen as an important issue for WHO. And many of the countries that they're working in are low and middle income countries, and World Obesity Federation is working with WHO and working with those countries to look at how to grow leadership there and to identify resourcing that can come into those countries to help with strengthening the health sector, but also looking at things like food procurement, urban environments, and so on. So it's quite broad. So, Jeffrey, it includes that, working in schools and so on, but it's also working a little bit more broadly at how at dealing with all of these broader issues that make it difficult for people to live healthy lives. But it also includes looking at the health sector. And some of the big challenges we have there are health professional training, because most health professionals aren't trained in the recognition and management of obesity. Yes, the odd surgeon or gastroenterologist or pediatrician is, but most people aren't. And we also need to make it much more accessible for people to have multidisciplinary team support, pharmacotherapy, and access to bariatric surgery. Easy to say that.
But those are actually excellent initiatives, especially when Gerhard was discussing the numbers in the Lancet study, saying it's 4-fold increase in adolescence in those 30 years in terms of the rate of obesity. One of the questions that we're receiving is about that in terms of what is the best diet, and what are you guys, WAF and WHO as well, WTO and IFSO, is there really a best diet that we should all be following?
The comment I would make is that we would normally recommend generally for people is to follow their national nutrition guidelines, national food guidelines they have, which are usually based on very similar issues around the world, which are around increasing vegetable and fruit intake, decreasing high sugary, high salt foods, and promoting healthful foods. I think that's a good baseline. The different question is what to do when you have established obesity, what might work for you. Our group and others have done quite a lot of work in adolescence, and the basic answer is what works for that young person, what they're going to like to do. And if they have support from, say, if you're in a situation where you can get really good support from a dietitian, then that can really work. Even very low energy diets can work in adolescence and be safe if given in a structured environment. But in the end, you're going to need to help people to transition to a longer term healthy diet that fits in with their lifestyle, their family budget, and fits in with their culture. It would be lovely if everyone lived a life with a reasonable amount of income, 50 years ago, but now we're in the 2024 and the world has moved on and there's a lot of unhealthy foods around. And also, we're also dealing, obviously, in different countries, people who have income and can afford more healthful diets, and people living in poverty, where it is far more difficult, and where the junk foods are often the available foods.
Which is, as we were saying before, when there is a question on the chat saying all these strategies that we've been talking about for the last 40 years have failed. And so where do we go next? And I come back to legislation, I come back to educating mothers with the youngest children and before they get to school, and then in school, increasing the access to exercise and sports in school, all of those things which we knew already, but adding to it that there should be taxes on foods that are unhealthy. So it's you mentioned Latin America and the taxes on soda. I mean, that's an obvious place to start. In Australia, as you pointed out, a relatively wealthy country. The highest or the most popular food that people buy at the local supermarket is Coca-Cola, followed by Sprite, followed by Fanta, followed by all the soda drinks. And that's what they give their children. And so, okay, if that's the case, maybe they need to tax them more and make them more expensive, the same way that taxes for cigarettes made them out of the reach for a lot of people. And we're seeing in Australia, certainly, smoking incidence has gone from 40% down to 20% in the last 20 years, or 30 years, as the price of cigarettes has gone up exponentially. So it's strategies. I mean, on the chat, people are asking the question, what else can we do? Well, the new drugs are a start, but prevention would be a great way to get in at the start.
I fully agree, and I think I like the comparison with smoking. In smoking, we speak about pack years. The longer you smoke, the more likely an end organ damage occurs. I would transfer this picture to obesity and speak here, let's say, about pound years. The longer the disease persists, the more likely you will see an end organ damage of various organs in your body. And I think this is very important, and Geoffrey very nicely pointed that out. We can mimic what happened with cigarettes, making them much more expensive, and the same with sugar drinks and all that stuff. I think that might be one way to go. Going back to the type of diet, I fully agree with Louise. Any diet that works will be successful, whether this is low carb, low fat, keto, whatever. The problem is keeping the weight down, the long-term weight loss. That's usually what people will tell you, doctor, I lost weight, but later on I regained all of the weight or the most of the weight. This is like a rubber band that pulls you back to some original point. And here I think the new drugs, but of course also metabolic surgery has a key role to play. And here I see also surgery in the future.
Mm-hmm.
I think you're right. But one of the questions I wanted to talk about were, as IFSO is talking about calling it not AOMs, because there's a pejorative there saying anti-obesity medication, but obesity management medications, OMMs. So that's hopefully a global change that will be accepted.
Mm-hmm.
But how, there's chat that talks about prevention. But really, as I mentioned before, I do think that we have an opportunity to prevent severe disease with, while we want to prevent the disease, we definitely want to prevent severe disease where now, we are intervening and can actually make successful long-term outcomes with surgery. But, I'm always say to patients, if you can lose the weight without me, then I also think that's one of the best ways to do it, right? Like, it's not that we are the answer, but for many patients, surgery is the answer. What are your thoughts on the OMMs and really prevention?
I think number one, ideally it would be the best to prevent obesity. But when we look at the worldwide numbers, until now, our efforts don't seem to be that successful. And therefore, we should not forget about all the people suffering from the disease. OMMs will play an important role in several aspects, preparing a subgroup of patients for surgery, those patients who have a certain amount of recurrent weight gain after the operation, maybe also support patients that undergo procedures that are not that effective. If you consider that only 0.5% of those patients who are eligible for metabolic bariatric surgery undergo the operation or that intervention, we must improve the access to that type of therapy. One way would be that we think about less invasive procedures and support or improve the effect of these procedures by the additional use of obesity management medications. This is one thought to make people more attractive to undergo certain intervention. I'm speaking here, for instance, of endoscopic procedures.
Mm-hmm.
Dr. Metz, so this is partly, advanced GI colleagues have many endoscopic options out there for the treatment of obesity. How do you see that impacting penetration, prevention of severe disease, and maybe remission to some degree of some of the obesity that we see?
Yeah, I mean, it's a question which obviously we've been looking at for a very long time, and we're disappointed on the first step, on the first treatments that were endoscopically introduced with the concept of putting balloons in the stomach. And they work on a short-term basis, but they're not a long-term solution. And so, as Gerhard mentioned, these treatments can be used as getting the weight down, and they generally, over a 3 to 6, or usually the studies are 6-month studies, they can get the weight down by between 8 and 15%, which may be enough to make the patients much safer for surgery than they were prior to the balloon. So balloon does have a place. They have recognized complications and side effects, but when you're really in a difficult situation, a patient with severe morbid obesity looking for surgery, then a balloon in that situation, we are saying is a short-term definitely possibility. More endoscopic techniques are being introduced to prevent absorption in the duodenum. That approach, which certainly they're experimental at the moment, but Gerhard would have a good idea as to how it compares with, say, the gastric sleeve or the more popular treatments. But endoscopic balloons only as a short-term treatment at this stage. What do you think, Gerhard?
Yeah, you're absolutely right. Balloons have to be removed after 1 year, and in the time when they are removed, weight goes up again.
Yeah.
Maybe now the new kid on the block is the endoscopic sleeve gastroplasty that shows 13.6% total body weight loss in a big RCT. So I'm thinking that maybe in that direction we will see more in the future, also when these methods improve furthermore. So I'm quite confident that this will be a more important role than it is today in the future, especially in combination with obesity management medications, as I mentioned before.
Mm-hmm. Agreed.
You know, we see this in the US as well, that there's a complete underpenetration in the utilization of successful procedures that can make an impact. I had made mention about GLP-1s, and we're seeing improvements in major adverse cardiovascular events in NASH, and they do have maybe associated with the weight loss some effect on lipid lowering as well. But Gerhard, I wanted to ask you specifically, when you are having conversations, you know, with other societies about the treatment using specific GLP-1s, because they have probably better results than some of the other weight loss medications that are out there in terms of these health-associated, obesity-associated health conditions and reduction. When we see a MACE reduction of 40% in surgery and GLP-1s, it's 20%. How are you having that conversation with our colleagues?
Thank you. That's an excellent question. I think why are GLP-1 analoga here superior? Because simply this answer is very simple. Because they induce more weight loss than all the other drugs we have seen before. And so they have a bigger impact on cardiovascular disease, on the liver, on also on diabetes, of course, lowering HbA1c much more effectively. Saying that, we have always keep in mind it's a chronic ongoing disease, whatever we do. So it's not to blame any medication or operation that it fails. I don't like the term, but to say it here, but we have to keep in mind, I always compare it with cancer. If one line fails, we have another line and another line. It's a multimodal ongoing treatment we have to offer our patients.
I think just to add to that, it's certainly true that I had a colleague who's a bariatric surgeon saying, it looks as if I'm out of business. These new drugs are going to stop surgery. Not the case. There's a long way down the road before there's any major impact. And in fact, you know, if we say that the obesity epidemic is getting worse, then these are really going to mitigate but not prevent surgery. I think it's as Louise was saying before, and Gerhard, it's a combined approach, and we'll have patients. I mean, a lot of these patients have diabetes. They'll have a combination of GLP-1s with insulin, but there will be ways of managing their diabetes and their obesity, but there will still be the need for surgery. There's no question.
I agree. I agree with all these comments, and I think the challenge for us is it's about which treatment for which patient at which point of time in their illness, and we're still learning about that. I think it's fascinating when you look at the RCTs, whether it's bariatric surgery, whether it's different types of lifestyle lifestyle intervention or different types of obesity management medication intervention, you'll always see somebody in the placebo group who actually does well, and they're receiving, and there's also always somebody in the active treatment group who's not doing so well. So what is it that distinguishes these different people? I think that's one of the fascinating issues. And there's clearly some people who are super sensitive to surgery and some less so at that time in their illness. Same with medication, and same to some extent even with dietary interventions or exercise interventions. So what would be lovely is to know which are, to be able to phenotype your patients at that time and be able to understand you're going to do really well with this form of combination of therapy. These people will need surgery first, followed by medication. These are going to need, psychotherapy first, followed by this, and so on. We can't quite have that degree of certainty in being able to manage that now as we would like. That's going to be the next 10 to 20 years of therapy as we do more trials, being able to better understand this. And now, if you think about the management of diabetes or heart disease, that evidence has been around for longer, or those equivalent types of evidence have been around for longer. So we're just learning this now. But I agree with the comments that both Jeff and Gerhard have said. And you too,
one interesting point you made, Louise, is that you look at the randomized controlled studies of GLP-1s and placebo. And as you said, the placebo group got a reduction of 8 to 11% in their weight. The GLP-1s got a much greater reduction. But I think part of the explanation for that is when you go to the doctor and the doctor's looking after you and the doctor's talking to you and the doctor's asking how you are. I've had patients come to me and say, I look at that cake, I look at that soda, and I think, next time I see Professor Metz, he'll be angry with me if I eat that, so I'm not going to eat it. and so it's I don't actually do anger, but I do express disappointment. And I think that a lot of patients, when you look at those placebos group who do lose some weight, it's because it does influence their behavior when they're coming back to see the doctor again in 6 weeks or 2 months' time.
But Geoffrey, that's exactly the point. You cannot your entire life meet Professor Metz every 4 weeks. You cannot do that. So, and when you look at the RCTs, they all end somewhere between 52 weeks and maximum 100 weeks. So 1 up to 2 years later. But we are interested in 5-10 years data.
Yes.
And then the picture is, of course, usually, unfortunately, a different one.
Correct.
Well, we are running out of time. I will tell you, on World Obesity Day, we at ASMBS, our leadership is here in Washington, D.C. to speak to our elected representatives about a Treat and Reduce Obesity Act. So I want to give each of you guys a minute or so to talk about what your initiatives are for this. So I'd like to start with Louise, please.
So we would recommend addressing stigma in weight-related stigma in all its forms, because that can really make a difference. It can open up avenues for people. Listen to the voices of people living with obesity, both adults and young people, and think about that, and think broadly about how you can actually support healthful environments, physical activity environments, urban environments, food environments, to support people living with obesity and people who don't have obesity, and then think about how people can have access to high quality, affordable treatments.
Gerhard.
I think IFSO has a lot of initiatives worldwide to raise the awareness. Of course, we are focused not so much on the prevention side, but as Louise said, to give people fair access to efficient treatment options, and of course also educate colleagues about the benefits of metabolic bariatric surgery, because often this is not known or even neglected. So there is a long way for us to go, and we try very hard in doing that.
Thank you so much. And Dr. Metz.
Yeah, it's always difficult at the end of the line because the others have said some wonderful things before you. But what I would add is coming back to the first point I made about prevention. I think we've got to work harder on that, especially with mothers and their young babies growing into children, going into school, proper food in school, taxing sodas, etc. So that's the prevention side. On the treatment side, it's a multidisciplinary approach. I think the days of the doctor looking at the patient and saying, stop eating, are gone. And we know it doesn't work, but the multidisciplinary approach is really important in your clinic. And then the third thing is, I think we will need these drugs. They are too expensive right now, but they will come down because as drugs are developed and they become more popular and they come out of their 7-year phase when they can't be duplicated by other companies, they will come down in price. And so there is hope for patients as well as the multidisciplinary approach. They will need to look after themselves, to talk to their team, but they'll also have the medications available even in the lower income countries as the prices come down. But it'll be a little while before that happens.
Okay, well, thank you all so much. I know we're actually pretty close to time, and this has been such a pleasure and honor to talk to all of you. And I look forward to all of us carrying out these initiatives to try and help all of our patients in the future, not just, you know, this year of our presidencies, but really trying to initiate processes that will help long term. But it is, no pun intended, a big problem, and we need to really use everything that we can, including, as Louise said, you know, engaging the youth and social media to try and get our message out. Thank you so much, everyone.
Thank you for excellent moderation. See you all. Thank you.
Bye-bye.